Welcome to the Renew Vitality podcast. We're here with our medical director out of Virginia, Dr. Bob Posner. Today, we're going to discuss testosterone optimization for our military and our military veterans. Welcome aboard, Dr. Posner.
Thanks for having me.
And then Andy Triggs, business director, business development of Renew Vitality.
It's great to be here as well again today, Ken. This is a topic that's near and dear to my heart. As you know, I retired from the United States Army as well. I'm very familiar with the options that are available both in the active duty military, the reserve component, as well as what's available to veterans. And I think Dr. Posner is going to be able to shed a lot of light on the rationale behind why active duty military members would benefit from testosterone optimization, the value of testosterone optimization for veterans, and the differentiation between the treatment that's available through the military or the VA and what's available through organizations like Renew Vitality.
Thanks. You know, Andy, I was a military doctor a number of years ago in the Navy. So I was in the medical corps and saw a lot of active duties back then. And then I went to private practice in the Northern Virginia area. And I saw a lot of people that work for the Pentagon, active duty, and also veterans, retirees. And there's a big absence of care often for this group of patients. They've served our country, and yet when they don't feel as well as they want to feel, they go through the military system. And unfortunately, they often get shortchanged in the type of care they get. So that's why I'm thrilled to be involved with Renew Vitality and taking care of everybody, but especially the military and veterans are really near and dear to me.
Absolutely. And the practice that you have with Renew Vitality in the state of Virginia is probably disproportionately military and veterans versus other types of patients just by virtue of where you're located. I know we have a lot of guys who sign up to come see you who either have served or are currently serving. You know, what are some of the ailments and issues that you find that are associated with members of the military or those who have served when it comes to issues you can resolve by optimizing testosterone?
Absolutely. Like a lot of the military patients come in with sometimes mood disorders. They're feeling maybe not clinical depression, but certainly low in mood, low in energy. They have low libido and a number of other symptoms that suggest testosterone imbalance. But then what happens, Andy, is they go to the military system, whether it be the VA system or if they're active duty, into the active duty clinics, tell the doctors what their symptoms are, have blood work done, and perhaps the testosterone level is in the normal range. But as we all know, that range is very large. It goes from the 200s to 900. And so if they're sitting there at 300 or 400, they're being told, well, you're normal. It's not a testosterone problem. But in fact, raising testosterone can often make them feel much better from their symptoms.
I completely agree. And after spending 2 decades in both the active duty component and the reserve component, I can tell you that I've been to plenty of military TMCs or military medical facilities. And in an entire career in the infantry, I never had my testosterone tested by the military ever, not once based on any symptom at all. I did have it tested with a VA, and their solution was to give me a small amount of injectable testosterone every 2 weeks, which I think every clinician at this point recognizes is woefully inadequate, causes a roller coaster ride. You get a high and a low. It's not necessarily the best way to administer it. But I think many military installations don't even look at testosterone. I think it's typically overlooked, and especially if someone presents with anxiety or depression or any other type of ailment, that a lot of times, medications like SSRIs or other things like that are prescribed, and testosterone is completely overlooked.
Andy, was it 200 milligrams at least, or when they prescribed you, the every 2 weeks?
Yeah, depot testosterone, 200 milligrams twice a month.
And Dr. Posner, do you see more of a decrease in testosterone in military patients and veterans?
The answer is yes, Ken. I often see that the military patients do seem to have lower testosterone levels than my non-military patients. I'm not quite sure exactly the physiology behind that, but certainly things like PTSD and other mood disorders, they do change neurotransmitters like serotonin and dopamine, but they can also impact peripheral chemicals like testosterone. So yeah, Ken, I think the answer is yes. I am seeing a disproportionate number of military people that have lower testosterone levels and certainly manifest symptoms that are helped by testosterone replacement.
Well, one of the things too I think that's beneficial is when you have people who need to perform optimally, like for instance, active duty military, and especially where your practice is located, there's a lot of sailors, there's the Pentagon's close by, you have a lot of special operations command folks. Those people would all benefit from optimized testosterone because they need to operate sleep deprived, they need to operate at a higher capacity intellectually, cognitively, physically. So having suboptimal testosterone levels wouldn't necessarily allow those people to perform at the highest possible threshold. So, testosterone optimization from a standpoint of practical applicability for, say, a special operator in like naval special warfare, wouldn't all those guys benefit from testosterone optimization?
Absolutely. Mood enhancement, but also concentration. Not that testosterone is positioned as an attention deficit medication, but certainly many patients do respond that they feel a better level of concentration and a more keen ability of acuity, mental acuity on testosterone replacement. So yes, I think military people often benefit greatly, not just from the libido and sexual functions that are historically attributed to testosterone replacement, but the mood and the concentration abilities are improved dramatically.
No, absolutely. And I think that years of stress and strain on the body, I think exposure to hazardous chemicals, I think, the strain, post-traumatic stress disorder. There's a lot of guys who have TBI or have had multiple, concussions and things like that, or have been exposed to, substantial amounts of, near contact with explosives, whether it's breaching or mortar, RPG fire, things like that. Those folks do have pituitary issues, or maybe not necessarily diagnosable, but certainly either clinically low or suboptimal testosterone, and the whole cascade of ailments come from that. The testosterone seems to be able to really help to resolve.
Absolutely. And it's not exactly just the number. And sometimes I have every patient will come in, well, what level are you trying to get me at? It's more an important function of getting a person to feeling better, which is what testosterone does. If that number happens to be 600, that's that person's sweet spot. If it's 900, that's their sweet spot. So we're not necessarily trying to titrate to a certain number. We want to get that person feeling much better. And again, in the case of my military patients, the results I see are actually amazing with testosterone replacement.
And the goal when administering testosterone is to produce a specific outcome, not a specific number. And that's why you're not so concerned about the specific number they start with, and you're not so concerned about the specific number they get to. The goal is to actually alleviate symptoms and resolve their issues.
Absolutely. There are certain parameters in medicine where the number is more important than a person's symptoms. As an example, blood pressure. Like hypothetically, if you came to me as an internal medicine patient, said, "Doc, I feel great, couldn't feel any better, but I find your blood pressure is 240 over 140, which is dangerously high." I'm going ballistic. I'm saying, "Andy, I get you to the emergency room for a shot to lower the blood pressure. Got to do this test of the heart, this test of the kidney immediately. It's a medical emergency." But he's, "Doc, I feel great." Well, high blood pressure causes a lot of silent damage to you. Now, conversely, testosterone. If you came to me as a medical patient and said, "Doc, I feel great, couldn't feel any better," and your level, let's say, was 180, I wouldn't feel as hard pressed to put you on medication for testosterone replacement. But with those symptoms, if your level was 300, 400, 500, you still would benefit from testosterone. And that's where the military often fails the veterans and the active duties, because if they see a normal testosterone level on blood testing, they'll blow it away and say, "No, not a testosterone problem, it's something else." But what is that something else?
Interesting. Also, Dr. Posner, what are some of these success stories you've seen when guys are like down in the dumps? I know we can probably start a small military with all the patients we have in Army and Navy. And I know that it helps a lot with depression when you get your testosterone optimized. So what are some of the success stories you've seen?
Ken, the answer is not some. It's like a lot. I started working with Renewed Vitality about 2.5 years ago. I had a much bigger practice. It was internal medicine, weight loss in Northern Virginia, but I sold that company. And I'm not somebody that's going to retire, so I started working with Renewed Vitality. So my experience with testosterone replacement wasn't very much up until I started working with Renew. But I was blown away with the results I was seeing in patients, because now I've been with them over 2 years. I get a chance to see people in follow-up. And so it's not just some case, it's people tell me it's a life changer for them, to the point where I actually, as you know, came down here to get put on therapy myself, because I want a piece of that action. People have life-changing experiences on testosterone. It's really amazing.
Well, I think this is one of the most important things that we can possibly discuss, and this is something that we harp on and that we preach here as an organization, is that it's not about testosterone replacement, it's about testosterone optimization. And optimization is very individualized, it's very customized, it is very result-driven, it is very symptom-based. And so everybody's testosterone replacement looks different. And it's not about a clinically low value. It's about everything we do here is basically driven based on patient symptoms, and the goal is all about patients' outcomes. And there's plenty of flexibility within that normal range to be able to produce results for patients without necessarily having to follow some sort of like laboratory minimum maximum guideline.
Well, you certainly don't want to over replace to the point where the testosterone levels are too high. But that's a great thing about Renew is that the company, the doctors, the coordinators are very much on top of everything with laboratory testing to make sure what we're doing is clinically safe and effective.
And so dosing is important, but then also follow-up lab work is important. And this is why it's so important to work with a clinician who understands testosterone, but is also looking to have adequate follow-up lab work and to be able to interpret that. And that's where dealing with experts such as yourself, someone who has enough experience with thousands of patients dealing with these types of issues. That's why it's so essential to work with somebody, not your general practitioner, or not to try to have the VA wing it, or not to try to do it on yourself with the guy at the gym. It's like, that's why having a professional physician who's an expert in, testosterone optimization therapy like yourself is the only route to go.
Well, again, this is certainly not to knock any military doctor or any other doctors in private practice, but for those that are not doing testosterone replacement, they'll basically be looking at numbers and really not taking into full account the patient's symptoms. When you're working with a doctor that has experience with testosterone replacement, the word you use was optimization. It's not necessarily hitting a certain number. It's optimizing symptoms and yet watching to make sure what we're not doing is over-replacing things. Another big point on this is testosterone. This is not about muscle building like for bodybuilders. This is about symptom improvement. And the military people come in with the PTSD, depression, low libido, low energy levels. They're looking to fix those. They're not looking to build muscles. They're looking to fix symptoms that are negatively impacting their lives.
No, absolutely. And there's a profound benefit to the folks who have served being served by our organization. And it's why your practice, I think, is disproportionately, military and veterans versus traditional patients because of where you're located, but also because of your approach and your willingness to really engage with those patients to help take care of them, to kind of serve those who've served. And I think that's a fundamental underpinning of your practice in our organization.
Well, I appreciate that. I have two offices. I have one office in Northern Virginia, which is near the Pentagon and all the military people up there. And then I have another office in the Hampton Roads and Williamsburg area, which services Norfolk and Virginia Beach, where you have all those military people down there. So I get a great opportunity to meet military people across the spectrum and veterans from all the way from the northern part of the state all the way to the beach.
Do we see a lot of active military?
The answer is yes. And I feel a little bit bad about that, Ken. I mean, I love taking care of these patients, but it kind of bothers. These active duty people are serving their country, putting their lives at risk. And yet the medical system oftentimes neglects their symptoms. These people need care, and they have to sometimes leave it. But I do my best job as possible taking really great care of these patients. I take care of best I can everybody. I have a special affinity for these military patients.
And another question I was going to have, kind of piggyback on the question earlier, are you seeing lower testosterone in younger military?
Surprisingly, the answer is yes. Now, I don't have any studies on that. I'm just giving anecdotal experience that the younger people, and I'm talking about people like below the age of 35, yes, they seem to have lower testosterone levels than my non-military people that are below the age of 35. And how I attribute that to is, once again, stress, PTSD, those type of things, I think deplete certain neurochemicals, but also deplete testosterone.
So same issues.
No, absolutely. And there's a whole litany of things that go into it. Like there's a lot of toxic chemical exposure that military are exposed to. There's a lack of sleep deprivation is a huge issue in the military. There's a higher stress threshold even in peacetime, or when they're stateside. Like it's a higher intensity job. There's a lot of things that go into it that negatively impact. I think the average soldier probably has more inflammation than a typical civilian does. So there's a whole broad array of things. And then they're also exposed to explosions and exposed to a whole broad array of things that can cause things like TBI and CTE and things like that, which are all correlated with issues where testosterone can help. And I think that depression and PTSD as well. That there's a lot of solutions that aren't necessarily helpful, like an SSRI, where it can cause potential sexual side effects, and it can cause a whole cascade of additional issues. And that testosterone is an underutilized drug that can help with these folks who've served or who are currently serving to mitigate a lot of those issues with way less side effects. Like the side effect profile of an antidepressant seems to be much worse than the side effect profile of an injectable testosterone replacement. And the benefits, a lot of times, not that clinical depression can be solved exclusively with testosterone, but it certainly can be a real value add.
Yeah,
Definitely a head start.
yeah, unfortunately, Andy, I think you're right on that. Oftentimes, the military people that go into the system, they get diagnosed with depression, anxiety, mood disorders, and get placed on the prescription medications you're describing. Now, maybe they'll help that mood issue, but they're going to not help libido. As a matter of fact, the reverse, as you mentioned. It's not going to really help energy levels, not going to help a bunch of other things like concentration. So I think the testosterone approach for these people is a much safer and better way of approaching not just their mood issues, but a whole bunch of other symptoms they're experiencing.
Absolutely. And the things like energy and recovery, the things like, preserving lean muscle tissue, all of the stuff that goes into the rationale behind testosterone being used as an anti-aging modality, those things also have value for people who are putting an overload on themselves physically and cognitively, where testosterone could help potentially to preserve the overuse of their body in the purposes of, serving in the military, as well as, the pressures cognitively or stress-wise to help mitigate, those potential issues by having optimal testosterone to be able to perform, at the best possible level physically and mentally, doing the course of their duties.
Mm-hmm. No, another word about, aside from military, I also see a good number of first responders too. Police, fire people that come in for the program. Because I think pretty similar to the military, they're under the same type of stress issues.
Well, I think there's a lot of there's been a lot of studies, I think, especially with police and firefighters, where they have a different version of PTSD because they have a soldier, a sailor, an airman, marine will go off to fight, and they'll go and they'll deal with these issues while they're on deployment. But a police officer, a firefighter, like they're dealing with trauma on a daily basis at work all of the time. So like they never get a pause, they never get a break from dealing with the chaos and dealing with all these traumas. So their PTSD is a near constant issue. So those guys sometimes have even more profound problems. And that's why we try to focus on helping first responders, military, veterans, everybody else. And testosterone has a place to be able to help all those people, whether they're currently serving in those roles or have retired or have left those roles, to be able to to resolve some of their issues with maybe non-traditional medications would create more problems than solve.
Mm-hmm. Mm-hmm.
So, but no, we're delighted to have you on board as our Virginia medical director. I know our patients are delighted by you, and especially, Renew Vitality has a handful of veterans that work for us, and we enjoy serving the military, veteran, and first responder communities for sure.
I mean, we need to serve the people that serve our country, basically. But on a serious question, who has the lower testosterone levels? Is it Army or Navy?
I think the Army guys have lower testosterone levels. We're kind of strong. Yeah. We got a lot of energy for us. Yeah.
Andy?
I think the Army Navy debate, it's a football issue between the two schools, between the two service academies. There has been a rivalry between those two organizations for as long as they both existed. So, you ask a Navy guy that question, I think you're going to get a very different response than. But I do think I would actually probably even agree with Dr. Posner, because most soldiers are dealing with a different environment than sailors are. The frequency in which they're physically, and there's exceptions to this, of course, but it would make sense potentially that an infantryman would have a different impact on his physiology doing his job carrying a ruck up the mountains of Afghanistan than a guy who's working on a submarine. You know what I mean? It's like, full disclosure, I've been the infantry guy and not the submariner, so I don't have the other experience, but it's also entirely possible that a more physically demanding job, and like I said, there's exceptions in both services, but that it wouldn't be impossible that potentially the Army could have lower testosterone because of the more physical nature of many of the jobs in the Army. So, but also too, it's you would expect a Navy guy, a swabby, to talk smack about the Army anyway. So,
Do you have time for a quick funny story, guys?
Sure,
All right,
absolutely.
okay. So the guy that developed fenfluramine, fen was phentermine and fenfluramine. The guy that developed fenfluramine, his name was Dr. Richard Wertman up at MIT. And that's when I was developing, and I patented a product, serotonin-based product. And fenfluramine worked indirectly by serotonin mechanisms. And I couldn't find a reason why you couldn't orally deliver serotonin. And my intent was to develop a patentable serotonin supplement. So I called the guy to pick his brain a little bit. He was like the expert in serotonin, right? This guy, like, I was able to get him because I was a doctor called. They got him to the phone for me. I said, Dr. my name is Bob Posner, internal medicine doctor. And he goes, you got 30 seconds. I said, why can't you use an oral serotonin? You can't get it across the blood-brain barrier. Click. That's the conversation. The guy was a prick. Right?
Was it a molecule size issue? Was it a delivery mechanism issue?
You can't find it, Andy. You can't find literature why it wouldn't cross the blood-brain barrier.
But isn't serotonin mostly produced in the gut?
It is, but it's also produced in the brain.
So it's but if it's mostly produced in the gut, how does it then get from the gut to the brain to take action?
I assume some of it goes across. Well,
because there's a huge amount of it's produced in the gut versus...
Liver's going to break it down, right? Liver's going to break it down. So anyway, that was my conversation with the guy. Fast forward years later, when fenfluramine was nailed, this guy was responsible for the biggest lawsuits ever in medicine. It was multiple $1 billion paid out for his fenfluramine medication. It was called Redox, if you remember that.
But it was a serotonin reuptake inhibitor, or was it
worked by serotonin? It made brain cells release more serotonin.
Gotcha. So it stimulated the release of
Correct.
serotonin.
Yes.
Is that why now there's also all these weight loss drugs? There's a couple of weight loss drugs that are FDA approved that actually have an SSRI, or not even an SSRI.
It's bupropion. It's a contrary. It's bupropion.
For sure. So and that is not an SSRI. That's
dopamine and norepinephrine.
So, and like in the state of Florida, there's actually rules that restrict that, where you can't use SSRIs or any of the other types of drugs for weight loss unless they're FDA approved.
Well, bupropion is
so that's where it restricts some of the compounding access. But if it is FDA approved for weight loss, it's allowable.
Mm-hmm.
But what's the mechanism then that serotonin plays in weight loss? Because it seems to be correlated with mood typically. So how does serotonin actually correlate with weight loss?
There's 7 different classes of serotonin receptors and different subclasses of each receptor, right? The 1A receptor, that's where the Prozacs and SSRIs work. That's involved with mood. But the 2B and the 1C receptors are involved with appetite. And so that's where Redox is working on. And that's where presumably my serotonin supplement was working on, by getting those receptors. So there are different serotonin receptors, and that's the explanation of why.
That's super interesting. So you're saying that the serotonin molecule can attach to different receptors, and where it attaches is the action it will take.
Correct. For instance, like migraine medications, like Maxalt, or people take Imitrex, right?
People with cluster.
They're 1D receptor agonists. There's this type of serotonin receptor. Another quick story about this. I get a patent issued on my serotonin supplement in the year 2000, something like that. And I put out a press release because back then I was advertising my practice. A phone call comes to my office from some woman saying she's from Boston, and she wanted to know a little bit more about my serotonin. And my staff gets to her name. Her name was Judith. She put her name Judith with a phone number. Well, I called her back, just, colleague. She was a pharmacist. Turns out with Judith Wortman, it was this guy Wortman's wife who was trying to do a little,
little probing?
Yeah, a little probing there. Yeah.
Outstanding.
Yeah.
So were you able to resolve the blood-brain barrier issue with oral serotonin?
I can't prove it goes across, but nobody can prove it doesn't. So I got the patent. I used it as part of my weight loss program.
Did you get some efficacy out of it? Like, did you see actual positive
Absolutely.
outcomes?
In the one controlled study we did, we saw about a 1.3 pound weight loss difference per month with people taking my serotonin versus just phenamine alone.
Really?
Yeah. Now, so that was
Did you ever combine them together, or was that?
No, yeah, they were combined.
You did them together as a combination?
The serotonin and the phenamine. That was my protocol. So we used the serotonin, phenamine, and then we started incorporating the GLPs much later. And then we had a dietary plan, and we put weekly visits in. So we charged like $1,200 for a 12-week program.
That's outstanding. So you did a great job explaining the receptor functionality of serotonin when it comes to weight loss. What's the difference in the mechanism then between how phenamine works and how GLP-1 works, for instance? Like, can you draw a contrast?
Much different. Yeah,
they're clearly very different drugs. So what's the difference between how they both work?
Phenamine's a stimulant, so that's going to work by 2 mechanisms. One, it's going to work on certain receptors in the brain to reduce appetite. The second thing it does is it increases metabolism, especially for women trying to lose weight that are over the age of 40. They know the metabolism levels are shot to shit, pardon my French. So they appreciate the increased metabolism. Now, GLPs are working on the gut. They're slowing the transit time of food from the stomach into the small intestine after a meal. So when you slow that transit time, it keeps the stomach dilated longer after a meal, and that sends chemical signals out to make us feel less hungry. So the GLP isn't impacting metabolism. Phentermine impacts metabolism.
So let me ask you this question then. So with phentermine, is it impacting metabolism because it increases heartbeat and respirations, and that's what's causing like the basal metabolic rate to go up?
That's correct. Yes, it does.
Outstanding.
Yes, it does. Yeah.
And then when you talk about GLP-1s, like I think everybody has the understanding of like how ghrelin and leptin work and things like that. But by slowing the gut motility,
Did you say
that what
everybody has an
increases?
understanding?
But by slowing gut motility,
That
do
wasn't
you,
gremlin, it was ghrelin.
I don't. Everybody in this room doesn't have.
when you slow down digestion, is that what causes the stimulation of leptin to signal the brain that you're
Correct.
satiated?
Those are the chemical signals that come out of the stomach
Gotcha.
that make us feel we're satiated.
So the
Yeah.
GLP-1, it hits both of those things, but it's more of the slowdown of the gut motility that causes the leptin release as opposed to the GLP-1 agonist actually hitting the receptor.
Correct. Yes.
Got it.
Yeah. Yeah.
And so you've had a lot of experience. You said 37 years in weight loss practice.
Oh, yeah. I've put like close to 50,000 people through my weight loss program over the years. Also, my program expanded nationally, so I was licensing my program to doctors across the country. So we were in a bunch of different states.
Outstanding. And what would you say if you were going to give advice to a weight loss patient? There's a lot of different drugs that can help to facilitate weight loss. Like, what would you say is the best way for a patient who's gone on any program, whether it's been on an OTC product or it's phentermine or it's a GLP-1? Like, what's the best way to maintain their weight loss after they're done with any protocol?
A number one step, Andy, is to have people understand the concept that long-term weight loss is not a diet, all right? There's not going to be a specific medication that's going to do it for you. It's obligating yourself to a behavior modification. Now, any medication could be a great adjunct to that process. So if somebody's trying to increase the amount of protein they're eating, reduce the amount of carbohydrates they're eating, it's good not to crave those carbs or feel hungry. That's where medication comes in. But at the same time, a person needs to learn how to change their long-term behavior patterns. And so it's not just as a doctor, you don't give a script for a weight loss medication and say, see you later. Like every patient I'm seeing in the program here with Renew Vitality, they're getting a copy of my dietary plan. So when I see them and prescribe the medication, I'm also giving them a dietary plan to follow and make sure they understand the dietary plan. Because without that, just the medication alone, yeah, they're less hungry, they'll eat less, and they'll lose weight temporarily. But what happens when that medication is stopped and the appetite comes back to baseline? They must learn a change of long-term behavior patterns.
And that makes sense, the behavior modification, learning portion control, understanding macronutrients, all of those things are key. Do you also talk to patients about physical activity, resistance training, things like that? Like, where else do you add the other components?
Exercise is always very important. Now, we've always heard of weight control as diet and exercise, almost like a seesaw with equal importance on both ends. But the dietary part is much more impactful. I encourage exercise, but if a person exercises like crazy and they're not following the right type of dietary approach, too many carbs, too much alcohol, skipping meals, the person's not going to do very successful long term.
Well, you can't outwork a bad diet.
Absolutely agree with that. I personally will go on the elliptical machine for an hour and a half, right? I burn off about 1,000 calories, good for Posner, an hour and a half. I could eat a double cheeseburger and fries that bring in 1,400 calories and literally do that in 10 minutes.
I've heard the difference metabolically between building muscle and doing cardio explained as like building muscle is like owning a rental property. It just earns you money while you sleep. Whereas cardio is like working on the clock hour by hour. You only get paid while you're doing the cardio. So it's like building lean muscle tissue and eating clean. That combination seems to be the winning combination when it comes to preserving fat loss and maintaining optimal body weight.
Mm-hmm. That's a great analogy. I love that.
That's a great analogy.
Yeah, it's really
So but no, I think that patients are best served by behavior modifications. So when they come to see you, not only do they get potentially a GLP-1 or something to help mitigate their appetite, but they get trained on nutrition, they get some guidance on exercise, and they're set up for success long after they finish whatever medication it is that you've used as an intervention to help them get that initial weight loss.
Yeah, support and accountability is an important one as well. 70% of our country, Andy, has a BMI over 25. So 70% of our country is overweight/obese. I think it's 40% are obese, BMIs over 30. If it was easy for people to lose weight on their own, those numbers wouldn't exist. So people really do need support, whether in terms of medication and or a provider with them working on it. But it's very hard for people to do this alone.
Well, and one of the things I think that's important too are like for people to understand, and there's so many young people who are overweight, and the whole concept of fat shaming has become a thing now. It's absurd that you can't tell someone that being fat is dangerous. Like it's super dangerous to be fat. Just like drinking alcohol in excess or even at all, it really isn't good for you. When it comes to being overweight, like what are some of the short and long-term like health concerns that that go along with obesity.
Well, the comorbidities of weight control, I mean, think of it as a centerpiece, and all around it, there's diabetes, high blood pressure, arthritis, chronic pain syndromes, dementia, cancer. All these are comorbidities of weight. Think of the most major cancers in America: breast cancer, colon cancer, pancreatic cancer. All of these things have obesity as a comorbidity, right?
So literally anti-aging, weight management, and maintaining a healthy BMI is literally one of the most important things you can do to help facilitate longevity.
I think it's the most important thing to maintain longevity is good weight control.
You know, one thing I've heard too is that they're now referring to Alzheimer's as type 3 diabetes. So they seem to have correlated insulin resistance with Alzheimer's. How does, out of control blood sugar, elevated A1C, or elevated fasting glucose, or insulin resistance, how does that impact, long-term cognitive function, or how does it impact Alzheimer's or dementia, or what are the negative aspects of uncontrolled blood sugar?
Andy, small vessel disease, when people have elevated blood sugars, it leads to an increased risk of small vessel blockage. And when you have ischemia, is the fancy name for lack of oxygen. So when you have lack of oxygen to certain parts of the brain, it results in brain damage. And those people are the ones who become demented. So the answer is it's all about blood vessels.
So controlling blood sugar and dealing with insulin resistance are imperatives, and you can basically mitigate both of those or help to modify both of them positively through maintaining a healthy BMI.
Absolutely correct. It's incredibly important.
Dr. Posner, you mentioned you give them a plan so they can be successful after the medication. But we're also discussing with Dr. Jockman also, what do you think about the long-term uses of the GLP-1s and seeing the more anti-aging benefits of being on the GLP-1s longer term, but on a smaller dose?
Yeah, I mean, the safety is pretty good. So my experience with this, now unlike a medication like phentermine which has been around for 60 years, these have not been around all that long. So what's the 20-year, 25, 30? We just don't know that yet.
Gotcha.
But thus far, what we're not seeing is any major issues, especially at lower dosages. So I think it's always risk-benefit in medicine. So if you have somebody with obesity, that's a pretty incredible risk for the things we mentioned: cancer, diabetes, heart disease. I mean, those are horrible comorbidities, right? Is the risk of a GLP at a real modest dosage, does that exceed the risk of those comorbidities? The answer is probably not. So it's probably safer to be on that medication.
Well, I discussed this with one of the other doctors because one of the patients were concerned with the side effects of the GLP-1s. And then the other physician was like, yeah, but hanging on to 50 extra pounds around your vital organs is not the better option.
It's one of the problems I've had in medicine sometimes. If I had a patient come to me for a consultation for my weight loss program and said, Doc, I hear what you're saying. I'm going to go back to my own doctor and see if the doctor thinks it's okay. I'll never see that patient again. Why? Because usually that doctor will naysay prescription medication. Well, there's a risk of the GLP. There's a risk of phentermine. But that same doctor is allowing their patient to be on blood pressure meds, diabetic meds, arthritis medications for being overweight. So at the end of the day, it's always evaluating risk versus benefit. And I think in the case of weight control, it's incredibly important to people to lose the weight.
And that's the clear differentiation between, and not to run down general practitioners and folks that are dealing with, everyday issues, because that's what they're trained to deal with. But the guys who are treating symptoms are very different than a guy like you who goes to treat root causes and to go resolve the actual problems versus dealing with the negative outcomes of poor lifestyle choices. Like there's a very clear differentiation between yourself and a provider who's just trying to treat symptoms with medications as opposed to actually fix the problem.
Well, again, and no knock on doctors, in medical school and residency training, I received 0 courses or minutes spent on preventing disease. It was all about diagnosis and treatment. So if that's the headspace you're in, you're going to diagnose and treat. You're not going to try to prevent.
Management.
Right. And so I think the paradigm is, actually, I spoke to one of my patients is in medical school now. Things haven't changed very much. There's still very little preventative medicine being taught in medical schools. That's insane.
It's wild too, because I've spoken to a lot of physicians. I've worked in this space a long time and worked with literally thousands of physicians working in compounding pharmacy and clinical laboratory and anti-aging medicine. I've had the opportunity to work with an enormous amount of doctors and to participate in all these symposiums and training seminars with clinicians. And Many of them have never had any formal training in nutrition, never had any formal training in exercise. They've never had any formal education in the utilization of nutritional dietary supplements. So they have a very pigeonholed perspective on the way medicine's supposed to be practiced. And I think they miss kind of a more holistic approach to being able to solve patients' problems and to mitigate future issues. So it's neat to see more of this holistic approach taking place, with practitioners like yourself.
When you look at stats, America is one of the most obese countries in the world. And there's a lot of reasons for that. These are processed foods. It's a whole lot of reasons that's too lengthy to get into here. But the point is, we do as a nation have to change this situation because we are spending incredible amount of billions of dollars on the comorbidities of weight control.
Absolutely. And I think the one thing that you really touched on, and this is where it becomes the most important, is that nutrition is the biggest driver of obesity. I've always heard the joke that a six-pack is built in the kitchen. And it's really true that if you want to look good aesthetically, your nutrition is the number one driver. Exercise is important. Cardiovascular exercise has its place. Resistance training is imperative. Hormones are essential. Supplements have enormous value. But if you want to be healthy, have a healthy BMI, have a lean aesthetic physique, your nutrition is the number one driver of all of that.
Mm-hmm. Absolutely agree with that.
Another question, Dr. Posner. 'Cause we're getting to this situation with the GLP-1s where it's massive weight loss that happens. Me, Andy, we both lost 50 pounds. So the doctors are more leaning towards not doing a ton of cardio while on the GLP-1s. I want to see if you agree with that, to not waste away a lot of the muscle too, because of how quickly they are losing the weight, if I said that properly.
I think if the dietary plan is prudent, meaning a high level of protein and low level of carb that's causing the weight loss, that high level of protein intake should help you preserve muscle. So I don't see that. And we have a body scan machine in my office that measures percentage body fat.
Mm-hmm.
What we're seeing is the weight loss is almost all coming from body fat. And
great.
So I think it's very safe to do. It depends where you start. A guy like you look pretty thin to me right now. So hopefully you're not really trying to lose any more weight.
No, I'm not.
But for the people that are 300 pounds, to see 50, 60, 70, 80 pounds coming off of them, you want to see that over time. You don't want that starvation diets or anything. You want them eating, but high protein, low carb. That's going to preserve your skeletal muscle.
And one of the things we preach around here too, especially, is when you're in a caloric deficit, macros become so important. And that's where prioritizing protein is key. And all the patients get told the same thing. I think the same guidance that you give them, all the other clinicians are doing something very similar, is to prioritize protein, as well as to engage in some degree of resistance training. Because if you preserve lean muscle, the GLP-1s can actually focus primarily on fat loss. And we're not necessarily looking to help patients lose weight per se. We want to change body composition and have a majority of the weight that comes off be body fat and retain that lean muscle tissue so they come out of the other end in a much better metabolic position. I think many times people who do these crash diets or the HCG weight loss back in the day or starvation diets or things like that, they lose a disproportionate amount of muscle or even equal amounts of muscle and fat. A lot of the brand name drugs had studies that showed equal amounts of fat and muscle loss. And I think there's a way to utilize a weight loss program, whether it be an appetite suppressant or a GLP-1, where you have adequate education when it comes to macronutrients and adequate education where it comes to resistance training, where you can make a majority of the weight loss be body fat and end up in a much more positive metabolic situation at the end on top of the behavior modifications.
And your point's really well taken. People sometimes focus on the body mass index, BMI, right? Anything above 30 obese, 25 to 30 overweight, below 25 normal. That doesn't take into account body composition. As an example, let's look at an NFL football running back, 5'11", 220. 5'11", 220, BMI is over 30. That football player is obese. But is that football player at risk for diabetes, cancer, heart disease because of the weight? No. That person probably has a percentage body fat of 6%. That football player is all muscle, right? Whereas a 5'10", 220-pound person with a percentage body fat of 44% is very much at risk for all those comorbidities. Same BMI as a football player. So we really shouldn't focus on the BMI. We should focus on body composition.
Absolutely. So we start with looking at BMI, but body composition, body fat percentage is also something you're measuring because that is a more relevant indicator. Because if someone's carrying 200 pounds of mostly lean muscle at 5'10" versus someone who's carrying 40% body fat at 5'10" and the same weight, they have two very different potential health outcomes.
It's like night and day, very different health outcomes.
So BMI is an initial starting point, but body fat percentage and body composition are really the real indicator of what your future health looks like.
And I would encourage people to try to find an InBody or some other body composition machine. Sometimes people have these home scales that purportedly tell you body fat. Those are really not very accurate. The InBody ones, the composition machines that doctors' offices will have, and sometimes gyms have those as well. That's definitely, even if they charge you $10, it's really worth the money to get that done.
Yeah, I have one of the scales at home that's it does the body fat percentage, and I look in the mirror and I can see the veins in the bottom of my abs. It says I have 15.6% body fat, so I'm pretty sure that the ones at home don't work that well.
Yeah, I agree.
How do you feel about like you said, the InBody scan? Like, do you encourage patients to get like DEXA, or are there other options? Like, there's more sophisticated stuff. Would you ever encourage a patient to get a DEXA scan, or would it be, they could do it with a much less expensive alternative? What do you think?
Most people know if they're carrying too much body fat. I mean, you can see it on the gut fat and such. But for those people that are not quite sure how much, like sometimes other patients, Andy, ask me, how much weight should I be? What should be my ideal weight? I'm not looking at a BMI for them or a weight that puts them at a BMI of 25. I'm saying if you as a male, I can get your percentage body fat down below normal, less than 25%. If I can get you down below 20%, I don't care what weight you are at that point. We got to have you at a healthy weight.
Well, I think that's exactly right. But then you're talking body composition as the primary focus, and they're able to preserve lean muscle. We spend a lot of time talking to, especially female patients for weight loss, and many of them are fixated on a number. And I'll kid around and say, what's more important, the number on the scale or how you look naked? And a lot of times women will laugh, but they're like, I'm way more concerned about what I look like naked in the mirror than what I look like with what the number is on the scale. And that's where we encourage the macros and resistance training and things like that, because a lot of times for a woman, especially when it comes to weight loss, their optimal metabolic situation is a higher weight than they'd assume, and they feel and look a lot better than they would had they hit the magical number that they thought they needed to be at.
Mm-hmm. When people shed body fat, that's when they notice the clothes size changes. So I have sometimes people that on the scale itself, it's not changing very much, but doc, I dropped two clothes sizes. They're losing body fat and gaining muscle. And that's what we want people to be doing.
Absolutely. All the time I hear guys, hey, I pulled my belt in 2 notches in the last 2 months. This is amazing. Like I'm making great progress. The scale, because they'll say the scale's not moving. And I'm like, well, what else is changing? Like, well, my sleeves are a little tighter because I've been hitting the gym 3 days a week lifting weights. And, I'm 2 more notches on the belt. Like I went from a size 40 waist. Now I got a size 38. They see some real substantial changes actually happening. And you're right. The weight can stagnate, but as the body composition changes, that's the key. And that's a lot of times the conversation that we have with patients is, well, are you seeing the changes that are happening that you want to have happen? Are you preserving lean muscle and losing fat? Once they have a recognition of that, it's like, okay, we're really making progress now. This is exactly what I want to do. And it's like, and that also seems to leave patients in a much better metabolic situation where their outcomes are able to be preserved and they're able to maintain that body composition change because they're in such a better metabolic situation when they started.
Mm-hmm.
I think Andy had 5 belt notches, right?
Yeah, it was ridiculous. I wore a size 40 jeans when I first started. I was busy, 3 kids, running around, working as a consultant, doing tons of. My nutrition was poor. That was the reason that I was about 265 pounds. And by the time the smoke all cleared, with a combination of secretagogues and GLP-1s and testosterone and a handful of other molecules and medications that we have, I went down to about 187. And I was just unbelievably lean. It was just, I've kind of bounced back up by putting some muscle back on subsequently. But it was really incredible. But yeah, I went from a size 40, bought a size 38 jeans, wore those for about 2 weeks, bought a size 36 for about 2 weeks, bought a size 34. I'm like, this is just ridiculous. I had to buy a new belt. By the time the smoke all cleared, I could probably fit into something smaller than the 32, but I'm just unwilling to go do that. I'm just, I could probably squeeze into a size 30, waist. But it's at 205 pounds, it's pretty cool. So the medications we have definitely can get you the results you're after. I'm one of those guys who believes in a maintenance dose of a GLP-1, and I take a maintenance dose, and it's allowed me to be able to preserve the progress that I've made. And I think from an anti-aging standpoint, the stuff that I've read when it comes to cardiac benefits or long-term cognitive benefits with mitigating insulin resistance and things like that, a little GLP-1, a little metformin over the long term, I think those seem to have a lot of promise,
Mm-hmm.
but there's blood sugar certainly is the enemy. And obesity certainly is the enemy when it comes to longevity.
I 1,000% agree.
And to put a bow on the nutrition side, when you start a GLP-1, you really have no room for error. Like, you have to eat well because you're not going to be able to eat much. So you got to get that protein in. Like you always say, Andy, prioritize proteins.
That's
Absolutely.
the number one thing I say to everybody. It's eat. I'm like, you go to dinner. I'm like, eat the steak first, then eat your greens. And if you get to the mashed potatoes, then if you have room left, I'm astonished. But it's always a macro discussion, and that's one of the things too. We have, there's a lot of dietary supplements that our physicians recommend. Preserving lean muscle, things like creatine, vitamin D3, K2, stuff like that has a benefit to preserving lean muscle tissue. And it's like, especially for GLP-1 patients, they integrate those into their program. Or if they're taking testosterone, which is a natural anabolic anyway, which helps to preserve lean muscle. It's like, if you can reduce your caloric intake and preserve lean muscle, the metabolic benefits are just profound.
Certainly back to the testosterone issue. I mean, that's also one of the reasons why testosterone levels are a little bit lower. Obesity causes that, low testosterone levels.
Makes sense.
As well as high estrogen levels.
Absolutely. And because the aromatase activity takes place mostly in adipose tissue, is that mostly where testosterone is converted into estrogen?
Correct, yes.
So basically, at the end of the day, if you're going to do one thing to help with longevity, body composition and body weight, not necessarily the fixation exclusively on BMI, but certainly improving your body composition and reducing body fat is probably the one thing you can do, the most important thing you can do to help with longevity.
That would be number one for me would be weight control.
Outstanding.
Yeah.
Fantastic.
Thank you for joining us for the Renew Vitality podcast. Thank you to Dr. Bob Posner for coming in from Virginia to join us today. Hopefully everyone gained a lot of insight from our discussion on testosterone in the military and with veterans and first responders, as well as all of the importance of weight loss and maintaining a healthy body weight. But join us for the next episode of the Renew Vitality podcast and like and subscribe. We'll see you again next time.